very exciting. I think if you know me, you have realized it's not hard to get me excited, but I am very excited. We are able to bring to you, especially for those of you that do ECIC bypass and are those brave hearts that believe that that works. It's very exciting to have somebody here that is putting data. There's not much being done in the US, and I would say probably worldwide, about putting data behind this procedure. And I think Nestor is one of those. He just presented, and he's hopefully en route to get funded for a new trial that is going to bring this back to life. Nestor Gonzalez is part of the Latin Power, Colombian by born, working now at Cedars-Sinai in LA. He's going to talk to us about EDAS for intracranial artery disease, results of URSHA's, his clinical trial on that. Nestor interviewed at Baptist before I got to Baptist, so we almost had the honor to work together, but muchas gracias. Thank you, Nestor, for being here. Honor to have you here. Thank you, my friend.
Good afternoon. Thank you, Ricardo and Nima and Eric for this opportunity to present the work that we have been doing on the management of patients with symptomatic intracranial atherosclerosis using EDAS, that, as you well know, is a form of indirect bypass. I don't have any commercial disclosures to make. All my research has been so far funded by the NIH and the American Heart Association, and I'm very grateful with them, as well as the support of my chair endowment from the Ruth and Raymond. Now, we have a very interesting series of presentations about the imaging and some of the pathology of intracranial atherosclerosis. And as you know, intracranial atherosclerosis is a common form of stroke. Now, traditionally, we have been thinking that it is a little bit less common than we actually see it. The rate of strokes that are due to intracranial atherosclerosis in the United States has been always reported to be around 10%. But this data is based on the North Manhattan study from 2015, and it really doesn't account for something that has happened in many of our cities. That is an increase in the diversity from different races. And while a stroke is a little bit less common due to intracranial atherosclerosis in white populations, it is significantly more common in African Americans, in Asians, and in Hispanics. So in Asia is a major form of cause of a stroke. As you can see in those numbers, in some countries it can be as high as 56% or so of the cases of acute stroke. And the truth is that in cities like Los Angeles, where I live, or in states like Florida, you have a significant amount of African Americans and Hispanics, and they also have a higher incidence of intracranial atherosclerosis. Now, so far, we have been doing things following what the cardiologists have done for the management of coronary artery disease. We started using first anticoagulation until the WASI study showed that probably antiplatelets was slightly better. And then the SAMPRIS and the VISIT trial attempted to compare the effect of angioplasty and stenting versus medical management. And both of those trials failed to show benefit of angioplasty and stenting in the management of patients with intracranial atherosclerosis. And there have been some controversies. We surgeons try to not believe trials that don't show the results that we want, and then we come with reasons for that. But the truth is that both studies were well done, and they show that there was an improvement in the results with medical management. The rates of strokes were around 14.1% with the medical arm, compared with 21% for the surgical arm. And the study was well conducted, was done in a good manner. And one of the interesting data of this study is a subgroup analysis that was pre-specified to look at different subgroups of patients and see how angioplasty and stenting would do compared with medical management. And although medical management was superior to angioplasty and stenting across the board in all the groups, it was also obvious that the medical management that has improved so much and that has benefits many patients is not equally good for everybody. there are still several patients that, despite intensive medical management, may get high rates of stroke. That include mainly individuals over age 60, and especially those who have had previous strokes in the same territory of the vessel that is affected. And in those patients, the risk of a stroke, even with intensive medical management, can be as high as 35%, which means that we don't have really a perfect form of treatment. And unfortunately, the results of these trials have basically tied, in a way, our hands, because what we can offer to the patients is medical management, and that intensive medical management is good. It's getting better with some of the new agents for the management of the cholesterol, but the medical management focuses in the alteration of the modifiable risk factors for stroke: hypertension, hyperlipidemia, diabetes, obesity, and smoking. That's what we do, and that's the way we treat patients with intracranial atherosclerosis. There is one factor that is a non-modifiable until now risk factor, that is the one that we had interest on, that is the factor of collaterals. This morning, there was a very interesting presentation of how many patients may have actually intracranial atherosclerosis, and the professor was showing slides of patients without symptoms with severe intracranial atherosclerosis. And the truth is that a key aspect that determines if somebody gets or not a stroke, even though they have intracranial atherosclerosis, are collaterals. And how to study collaterals have been one of the interests in the group in which I was at UCLA and currently where we are at Cedars. So collaterals, however, cannot be modified in the sense that some people have good collaterals, some others don't have good collaterals, and that is an important, until now, non-modifiable risk factor for a stroke. So a few years ago, out of pure need, in patients in which we knew they were having symptoms just by lifting up the head of the bed in the ICU, that have severe intracranial atherosclerosis and were so sick that we couldn't even do an angioplasty and stenting, some of them with stenosis that were so long that there was no balloons or things that we could really apply. We did few cases, around 12, in which we did an indirect revascularization, that it was a technique developed in Japan for the management of moyamoya disease. And those patients did actually okay. So we put together that data, put some pilot study and presented it to the NIH, and I got funds to do a phase 2 study to evaluate if EDAS, a form of indirect revascularization, could be a good alternative for the management of patients with symptomatic intracranial atherosclerosis. And I work with both the stroke centers of UCLA, that is my alma mater, and the Cedars-Sinai Stroke Center. We are very close in town and we work together very often, and put together this study, which results I'm going to present to you. And of course, the rationale for this is that, as I have discussed at the beginning, there is no good treatment for intracranial atherosclerosis, and those rates of stroke in symptomatic patients can be as high as 35% in medical management. The second thing is that we should be honest. When something doesn't work, doesn't work. That's why we do clinical trials. And of course, I like to do regular bypasses. I love to do angioplasty and stentings, but if it doesn't work for the patient, I cannot honestly offer them that and tell them that they're going to do well. Clinical trials have shown that those techniques don't work. And when something doesn't work, we can insist, like we did with the ECIC bypass trial, and then repeat the trial, like we did with COS, to show almost the same result, that bypass didn't work, that medical management was superior. Or we can start thinking outside the box and, beyond intensive medical therapy, develop other options in which we can try to alter the natural history of this disease. And that's what we did. And why EDASes? Well, these are delicate patients. Doing a regular bypass in 2 clinical trials had shown already that didn't work. So maybe an indirect bypass could work. There was one main disadvantage. EDASes that are indirect bypasses don't produce vessels right away. So it takes a while for neovascularization to occur. How long? We really didn't know. But there were numerous advantages. One of those is that it's less technically demanding. So it takes a shorter time in the OR to do an indirect bypass than what it takes to do a regular bypass. There is no requirements for temporary occlusions of vessels. When you do a direct bypass or a real bypass, you have to occlude the middle cerebral artery or the carotid, whatever is your recepting vessel. And if you are occluding a vessel in a territory that is already at risk of a stroke, you have a chance that that may induce the stroke. There is actually no manipulations of the stenotic segment. You are not passing wires or balloons or putting stents where the plaque is, which can dislodge clots or can produce thrombosis on the plaque or thrombose perforators. And something very interesting that happened in the ECIC bypass trial was that in that trial, they included also patients that have stenosis, not only occlusion. And the patients that had stenosis did worse than the patients with occlusion. The majority of them got strokes, not in the cortical territory, but in the basal ganglia. And probably part of what happens, and we have shown this in the lab, is that when you put a bypass and you have a severe stenosis, there is a competitive flow between the bypass and whatever gets to go through the stenotic segment. And if the stenosis is more than 90%, an STA bypass that is robust could potentially produce a virtual flow of zero at the level of the lenticular striated vessels, producing thrombosis of those vessels and more strokes. That's why when we designed COS, we didn't include patients with stenosis. We concentrated in occlusion. As I mentioned before, it didn't work either. So the final thing is that when you do a bypass, you face occasionally two issues. One is the hyperperfusion, the risk of hemorrhage, and a little bit of edema. It's usually not that problematic, but it is a true problem in some occasions. With the indirect bypass, you don't have that issue because the vessels grow progressively, so it is very rare that they develop, actually I have never seen it, a serial edema or hemorrhages. So what is the EDA surgery? I'm going to take some of the minutes to show some of the modifications that we did to treat patients that were essentially different than the ones for which the EDA surgery was initially created. EDAS was done for pediatric patients with Moyamoya disease. These are almost the complete opposite. Usually very old patients, adult individuals that have high risk of having strokes when you're trying to do this operation. So the first part that we changed is that we did a very strict cardiac evaluation and anesthesia evaluation to be sure that they will have at least some level of resistance, that they will tolerate to have a little bit of hypertension during the surgery and the first few weeks postoperatively. The second was a modification of the EDA surgery in which we basically emphasize something with our neuroradiologists, our neuroanesthesiologists, and is that the surgery for patients with neurosurgical problems usually are handled by anesthesiologists that are trained for traumatic brain injuries or tumor surgeries. So they tend to do several things. They tend to hyperventilate the patients. They tend to give them mannitol or diuretics to reduce the brain swelling. They may actually intentionally use medications that produce vasoconstriction, and they want to keep the patient as much as possible dry. So it's very common that you have to stop aspirin or Plavix or medications like that to do those surgeries. What we wanted to do was completely different. We need patients that require actually maintaining a blood pressure in the levels in which they have been asymptomatic. So we are strict in our anesthesia protocol that they should not have any dips in the blood pressure that last more than 5 minutes, and it cannot be at any point below the systolic blood pressures in which they are asymptomatic when they're awake. We avoid completely hyperventilation and actually insist in doing normocapnia to be absolutely sure that there is no vasoconstriction. We prevent dehydration, so we load them with fluids at the beginning of the operation and don't use any mannitol during the surgery because that can transiently make them intravascularly dry. We maintain a fluid balance that is even or up to 2 liters positive, and we don't use any steroids during the surgery to promote the growth of the vessels. And a very similar management is translated then to the ICU for the postoperative care of these patients. Now, the surgical technique is not much different than what you have, those of you that are surgeons that have learned for patients with Moyamoya. We like to mark with the ultrasound the artery so we know exactly where it is. It's very important that the artery is dissected on top of the artery. And the ultrasound allows you to, the little Doppler ultrasound allows you to mark that very effectively. Then we suggest that the surgery should be done from the beginning with the microscope. The reason for that is that you have a lot of control of small bleeders. You don't have to come back for hemorrhages. And remember, these patients are taking aspirin. We don't stop the aspirin. And we use a low voltage in the coagulation. It's usually no more than 20. As you see, we are opening the skin and then taking care of all the little bleeders right away. And once you do that, the dissection actually becomes quite dry. The artery is easily identified, and we prefer to cut a cuff that is relatively close to the artery, no more than 2 or 3 millimeters, because the growth of new vessels, if you have a very long cuff, may be a little bit impaired. Then we open a craniotomy. The craniotomy is an elliptical craniotomy which size is pretty much defined by how much of the artery you dissect. It's usually like 10, 12 centimeters. And we preserve as much as possible the meningeal artery branches. In some of the papers that we have published, we have seen that some of the vessels that grow into the brain are coming not only from the superficial temporal artery, but some of them come from the middle meningeal artery. So you see those yellow arrows that are indicating branches that we try to preserve when we're doing the operation. Then, very carefully, we open the arachnoid, which accomplishes 2 functions. One is releases some of the CSF. So as you are not using mannitol, the brain sometimes tends to swell a little bit, not that much in elderly patients, but it can do. And this one, by releasing the CSF, then it comes down without the need of using mannitol, diuretics, or hyperventilation. But also removes one of the barriers that normally would be impeding the growth of new vessels and the connections of those new vessels with the arteries of the brain. Finally, we peel the dura mater. The dura has several layers, and we peel it just like open one of those cheese strings packages. And we do that because the inner layer of the dura is quite fibrous, and I think it obstructs a little bit the growth of vessels. Some other groups decide or have flipped the dura mater inside out as another option, but I think this one actually promotes the growth of vessels. And then we quickly suture with an 8-0 or a 9-0 suture the cuff of the artery to the edges of the dura, not closing the rest. This prevents much of horizontal movement of the artery that may happen during the pulsation, that if it is too intense may prevent vessels to form. Then we put a little collagen sponge on top, put the bone back. Usually the craniotomy is not that circular, it's a little bit more of an oval craniotomy with 2 holes, one for the entry of the artery, the other one for the exit of the artery, and close it up. And what we have seen is that these vessels start growing. So using that technique, we completed recently a prospective single-arm study of EDAS plus intensive medical management. We included patients that were very, very similar to the patients of the Sampris group. Where there was only a couple of exceptions. One of those is that we included also patients with obstructions, but other than that, we use exactly the same inclusion criteria of Sampris. That means that we included patients that were symptomatic within 30 days of the enrollment. This is very important because the higher incidence of strokes after intracranial atherosclerosis, etiology of a stroke, is in the first 30 to 90 days. If you wait after that, the rate of strokes dramatically fall. So recent registers like the WIF registry, for example, have shown that the rate of stroke is very low with angioplasty and stenting, but none of those patients really were treated in the early period where the risk was higher. And that is the problem period. That is when the time is necessary to be addressed as an issue for the management of these patients. So we also wanted to see if collaterals had an impact, and we planned the study to include only patients that have poor collaterals in angiography. So all the patients receive an angiogram, and we maintain exactly the same medical management that had been established in Sampris, which meant that basically we were controlling these patients very closely, having them having a good diet, controlling strictly their blood pressure, in some cases supplying the medications to be sure that they were compliant with that, and we maintain the antiplatelet therapy. The primary endpoint of our study was the composite of death or stroke of any cause within 30 days of surgery, or any ischemic stroke in the territory of the qualifying artery at 1 year after the surgery.
Hey, how you doing?
Also evaluated as secondary.
Good.
Modified
You know,
ranking.
I may be on Facebook Live now.
Degree of
I don't know.
the cognitive.
I'm sure you don't want our conversation going on Facebook Live.
The clinical endpoints were evaluated.
I'm in a conference now. I'll be done in a couple hours. So I'll talk to you later, okay?
Well, so I don't want to be perception of how a good surgeon I am. for that reason, it's better to have independent assessments of neurologists. They are very critical. Usually they find little things and pronator drifts and things like that that I don't. So that was the way we designed it. And of course, the hypothesis that we have was not to prove that this is effective. We're not quite there yet, but to prove that this was good enough, that it's worth it to move along the lines of the establishment of the pipeline of research, and then now do a pivotal type 3 a pivotal study or phase 3 study to demonstrate that EDAS works for these patients. But so this is a phase 2. It was just to see if we could show that there's enough benefit that is worth it to invest the money of a very large phase 3 clinical trial. And to do that, we were planning to compare the patients that we enrolled with a comparator extracted from the SAMPRIS trial. Have the issue that we included also patients with occlusion. So SAMPRIS didn't include patients with occlusion, so we did a propensity score matching with patients with intracranial atherosclerosis. Cost clinical trial to compare them in the case of occlusion or stenosis with those individuals. And this is the general flow of our study. We have 65 consecutive patients that were offered surgery. Of those 65, we have to exclude 13, mainly for cardiac reasons. 5 of them have unstable angina or the compensated on Zoom. 5 have large infarctions. That was a contraindication to the operation. 2 were still smoking up to less than 3 months from the time of surgery, and on that we have been very strict. If a patient wants to be treated, they need to have at least stopped smoking for 3 months, which means that they're committed to their own care and that they're gonna be compliant with the medical management. And we have, I think, 1 patient, yes, that exceeded the body mass index that we have as a limit for the surgery. The other 52 patients were eligible. We did angiograms for those 52 patients. All of them have poor collaterals, so we didn't have to exclude any patient because they have poor collaterals, which points probably to the point that it's unnecessary to do the angiogram. It seems that they are having symptoms when they have already poor collaterals. And those patients underwent the surgery plus intensive medical management. The members of the stroke team, the stroke neurologists, follow them at 4 days, 30 days, and then every 3 months for 2 years. We're still following those patients. And all of them got angiograms at 6 months and 1 year from the time of surgery. And these are the results of that study. We included 32 females. The mean age was 52.3 years. And the qualifying events, the majority were strokes. Strokes at 17 was.
I did notice something unusual.
The most common location of the stenosis or occlusion was in the intracranial carotid artery, followed by the MCA, and then by combinations of those two. We have patients really with very, very significant stenosis. The mean stenosis was 92.5%.
Okay, you want me to restart it? I can just restart it with a new Zoom thing.
Have occlusions.
See how it does without this.
We're still following the patients, and we haven't had any dropouts. We are really like hawks following them, so we don't let them get out of our site. And we have completed for the angiographic studies almost 94% of that at 6 months. And